Yeah, my name is Heun. I'm a consultant psychiatrist, and today I want to talk about anorexia nervosa in our series Mental Health Explains from the Global Psychiatric Association. Anorexia nervosa is a disorder in young women mostly, but also more and more in men. It's a distortion of body image and a pathological desire to be thin. And in the wish to be thin, people do different things, induce vomiting and use other ways of trying to lose weight. Sadly, there is a 10% mortality, sometimes a quarter of that is suicide, but very, very often it's also the consequences of the weight loss actions. Usually there are more females, 1 to 10, but it depends a little bit on the diagnostic criteria, as everything in psychiatry. Usually it's about late teens, but sometimes people start in their 30s, which is more uncommon. And the incidence, which means the new appearance, is about 1.5% of adolescent and young women. The prognosis, as I said, is quite bad. Many people will have problems all their lives. If they're treated, there is a chance for a full recovery from 30 to 40%. But in other cases, things might get worse. If it's chronic, it's already worse. The late age of onset is not a good diagnostic criteria or a prognostic criterion, and previous bulimia, which vomiting, purging, is also a poor prognostic criterion. So what are the diagnostic criteria? It's low body weight, the body mass index of 17.5 or less. Usually when the body mass index is less than 14, people are admitted to hospital because there are so many metabolic problems that might be fatal. I might come to the body mass index in another day. So on top of low body weight, there's a self-induced weight loss. So people trying to avoid fattening foods, whatever that is. They induce vomiting, purging. They try excessively exercise and lose weight, and they sometimes use appetite suppressants. There is this feeling of fatness, the dread of fatness, and if people are very thin, they might still say, "Oh, I'm very fat because I have a couple of whatever, a bit of a belly here or there," and they try to see themselves in the perfect image, what they might see on the videos on TV. Usually there is endocrine problems. The HPA axis might be disturbed. People, in consequence, have amenorrhea, so they have no periods anymore. They have reduced sexual interest. The growth hormone levels might be raised. Cortisol might be disturbed, and the insulin secretion might be abnormal. But usually these endocrinological problems are not the diagnostic criterion. The diagnostic criterions are the low weight and the exercise and the ways a patient uses to lose weight. Right, puberty might be delayed as well if it starts early. The body mass index, maybe I talk about that now, is the weight in kilograms divided by the square of the height. So let's say that way. You have, let's just make it simple. You have a weight of, let's say, 80 kilograms, and your height might be 2 meters. Let's say, can make it simple. So you have then the height of square meters. So your 80 kilograms height is 2 square meters. So you would then divide the weight by 4. So you would have a body mass index of 20. So that's people with 2 meters are not very common, but for the master, it makes it much easier. I'm sorry for that. Right. So on top of that, there's a differential diagnosis. So people sometimes might have chronic diseases like which affect the malabsorption of food, especially fat, like Crohn's disease. Brain tumors might affect the appetite, same as dementia sometimes might cause a loss of appetite. Sometimes it might be medications such as SSRIs, or depression and OCD might affect the appetite. There's a big genetic contribution, usually when the concordance between monozygotic twins is much higher than those between dizygotic twins. So, and this is the case in this disease. So you have a significant genetic contribution. Some people might say previous adverse life events might contribute to that. It's very, very difficult. Some people might say that people have had the suffering of physical and sexual abuse. Sometimes, psychodynamic models focus on family pathology, rigid, overprotective family, and lack of ability to resolve the conflict, and the conflict then is transferred to the fight about the body weight of their child. There's other, problems which might be relevant, such as restrict food or specific attitudes of towards food by the parents. There are some ideas of psychoanalytical problems, that people might be fixated in the oral stage. So oral stage means that all things eating are very important. There might be neuropsychological deficits, sometimes reduced vigilance, and poor memory, so associative memory might be changed. There are reduced changes in the brain imaging if the anorexia nervosa is progressed, because everything shrinks and the brain also does shrink. Other eating disorders might be relevant as well. So bulimia has a bit of a history of that. There are typical eating disorders, very many where some of the key features, such as the low body image or brain image distortion or different perception of fatness, are not really relevant. So the question is, how do we come forward with the treatment? But we will talk about that next time. I try to keep it short and simple. I'm not sure whether this is the way to do it, but if you have any ideas of improvement, our lectures, which it essentially want to teach and help reduce or help increase mental health literacy. Mental health literacy has the idea that better knowledge on mental health problems will reduce the stigma and will improve the access to care and treatment. If you like this, please subscribe to our channel, and I hope you enjoyed the talk, and have a nice day then. Thank you so much. Okay, now we end it.